Hello, this is Dr. Oviedo. Today we are going to go over the pathology of vasculitis. These are the lecture objectives. Before we start, I want to discuss some general concepts. Vasculitis is a general term for vessel wall inflammation. It can affect different vascular beds. There are many different classification systems based on vessel type, the role of immune complexes, presence of specific autoantibodies, granuloma formation, or organ specificity. The vasculitis disease mechanisms are quite complex and include immune complex deposition, anti-neutrophil cytoplasmic antibodies, anti-endothelial cell antibodies, and autoreactive T cells. The other reason this classification is complex is because these diseases can be classified clinically by the way the patient presents and what organs are affected, and vasculitis can also be classified pathologically, which means based on the appearance of the lesions involved under the microscope. This is one of the drawings from Robbins. It summarizes which parts of blood vessels are affected in particular types of vasculitis. Laboratory and pathology diagnosis play a major role in the care of patients with vasculitis. C-ANCA, which is now known as PR3, is a neutrophil granule constituent that shares homology with numerous microbial peptides. P-ANCA is now known as MPO-ANCA. Myeloperoxidase is a lysosomal granule constituent involved in free radical generation. PR3 and MPO-ANCA are used to aid in the diagnosis of different types of vasculitis. Immunofluorescence is also done on tissue biopsies. We will not be covering this topic in today's lectures. Let's start with giant cell arteritis, which is also known as giant cell temporal arteritis. This is the most common form of vasculitis among older individuals in the United States and Europe. It is a chronic inflammatory disorder of large to small-sized arteries that principally affects arteries in the head, especially the temporal arteries, but it can also affect vertebral and ophthalmic arteries. The ophthalmic artery involvement can lead to permanent blindness. The clinical presentation is generally facial pain or headache, diplopia, and vision loss. It can also have fever, fatigue, and weight loss. It generally occurs in patients over the age of 50. The pathogenesis is a T-cell mediated immune response against vessel wall antigens that drive pro-inflammatory cytokine production, particularly TNF. Anti-endothelial and anti-smooth muscle cell antibodies are present in approximately 2/3 of patients. Here are some photographs of giant cell temporal arteritis. Go ahead and test yourself. The answers will be on the next slide. You can see in the middle panel this artery demonstrates significant intimal proliferation, and this artery would not be able to transmit very much blood. On the top right, you can see giant cell or granulomatous inflammation against the elastic lamina. The elastic lamina is fragmented. You do need special stains to see the elastic lamina fragmentation, which we do not have here. On the bottom, you can see there is also significant lymphocytic inflammation. The prognosis of giant cell temporal arteritis is good with corticosteroids or anti-TNF therapies. Let's go on to Takayasu arteritis. This is a granulomatous vasculitis of medium and larger arteries. These patients can have ocular disturbances and marked weakening of the pulses in the upper extremities. The aorta will demonstrate transmural fibrous thickening, particularly of the aortic arch and great vessels, with severe luminal narrowing of the major branch vessels. It can also involve the pulmonary artery, coronary, and renal arteries. The clinical presentation can include initial symptoms of fatigue, weight loss, and fever. Vascular symptoms with progression of the disease include reduced blood pressure, weak pulses in the carotids and upper extremities, ocular disturbances, neurologic deficits, leg claudication, which means leg pain induced by exercise, pulmonary hypertension, myocardial infarction, and systemic hypertension if the renal arteries are involved. This generally occurs in patients less than 50 years old. If the patient is older than 50, we generally call it giant cell aortitis. Here's the pathology. Go ahead and describe the photographs. The answers will be on the next slide. You can see on the left, the aorta has significant intimal thickening. On the top right, you can see there is giant cell inflammation against the elastic lamina, and there are also lymphocytes present. This histology is very similar to the giant cell temporal arteritis, but of course it is affecting the aorta. Takayasu Arteritis has a variable disease course. Some patients have a rapid progression. Some patients enter a quiescent stage after 1 to 2 years. Let's go on to Polyarteritis Nodosa. This is a systemic vasculitis of small or medium-sized muscular arteries. It typically involves renal and visceral vessels but spares the pulmonary circulation. It has an immune complex-mediated etiology. 30% of patients have chronic hepatitis B with hepatitis B surface antigen, hepatitis B surface antibody complexes in the affected blood vessels. This is typically a disease of young adults but can occur in pediatric and geriatric populations. There is a remitting and episodic course with long symptom-free intervals. It can present with rapidly accelerating hypertension due to renal artery involvement. It can also present with abdominal pain and bloody stools due to gastrointestinal involvement. It can present with peripheral neuritis, predominantly affecting motor nerves. Polyarteritis nodosa can have remission or cure in up to 90% of cases with immunosuppression, but is fatal if untreated. Here's the pathology. Go ahead and describe the photographs. The answers will be on the next slide. You can see the skin punch biopsy has an artery with fibrinoid necrosis. That's that bright pink area. There is significant transmural inflammation of the arterial wall. Here is another case of polyarteritis nodosa. Go ahead and describe these slides. The answers will be on the next slide. This artery shows thrombosis, which is circled in blue, in addition to the inflammation. Let's go on to Kawasaki disease. This occurs in infancy and childhood, generally in children less than 4 years old. This is an acute, febrile, usually self-limited illness, also known as infantile polyarteritis nodosa. The histology is similar to polyarteritis nodosa. It has a worldwide distribution. It is the leading cause of acquired heart disease in children. The arteritis affects large to medium-sized and even small vessels. It can have coronary artery involvement that can cause aneurysms that rupture or thrombose, causing myocardial infarction. The pathogenesis is unknown. The clinical presentation can be conjunctival and oral erythema and blistering, edema of the hands and feet, erythema of the palms and soles, desquamative rash, and cervical lymph node involvement. Approximately 20% of untreated patients will develop cardiovascular sequelae. Intravenous immunoglobulin and aspirin early in the course will reduce the risk of symptomatic coronary artery disease. Here is our gross picture of Kawasaki disease. Go ahead and describe it. The answer will be on the next slide. You can see this heart has a large aneurysm of the left anterior descending artery, which is circled in blue. The histology will, of course, resemble polyarteritis nodosa. Let's go on to microscopic polyangiitis. This is a necrotizing vasculitis that primarily affects capillaries as well as small arterioles and venules. This is the same thing as hypersensitivity vasculitis and leukocytoclastic vasculitis. It involves skin, mucous membranes, lungs, brain, heart, gastrointestinal tract, kidneys, and muscle. Necrotizing glomerulonephritis and pulmonary capillaritis are particularly common. Microscopic polyangiitis is a feature of Henoch-Schönlein purpura, which is a childhood illness with IgA deposition and has a tetrad of rash, arthralgias, abdominal pain, and kidney glomerular disease. It is also a feature of essential mixed cryoglobulinemia, which is associated with hepatitis C or HIV. Mixed cryoglobulinemia means both IgM and rheumatoid factor are present. Cryoglobulins are immunoglobulins that precipitate in the cold. The pathogenesis is an antibody response to antigens such as drugs or microorganisms which cause immune complex deposition or trigger secondary immune response, such as MPO-ANCA. The pathology is generally referred to as leukocytoclastic vasculitis. The clinical presentation will depend on which vascular bed is involved. Immunosuppression can induce remission unless there is widespread renal or brain involvement. Here are our photographs of microscopic polyangiitis, which has the pathology called leukocytoclastic vasculitis. Go ahead and describe the slides. The answers will be on the next slide. You can see the skin punch biopsy demonstrates a small vessel with fragmented neutrophils and fibrin. Let's go on to Churgstrauss Syndrome. Churgstrauss Syndrome is a small vessel necrotizing vasculitis which is classically associated with asthma, allergic rhinitis, lung infiltrates, peripheral hypereosinophilia, and extravascular necrotizing granulomata. This is very rare and occurs in 1 in 1 million people. The histology is similar to Polyarteritis Nodosa or microscopic polyangiitis, but is accompanied by granulomas and eosinophils. MPO-ANCA is present in half of patients. This is a multisystem disease with cutaneous involvement, gastrointestinal tract bleeding, renal disease, and myocardial involvement. Here is the pathology of Churgstrauss. Go ahead and describe the slides. The answer will be on the next slide. You can see the skin punch biopsy demonstrates small vessel inflammation with eosinophils. On the lower right, the eosinophils are infiltrating through the collagen. This particular case did not have granulomas. However, granulomas usually are a feature of Churgstrauss. Let's go on to Bechets Disease. This is a small to medium vessel neutrophilic vasculitis. It has a clinical triad of oral aphthous ulcers, genital ulcers, and uveitis. It can also have gastrointestinal and pulmonary manifestations. It has an HLA-B51 association. Th17 cells recruit neutrophils, however, this is a nonspecific finding. Clinically, this is a disease of young adults and is more common in males. The pathology is that of leukocytoclastic vasculitis. Let's go on to granulomatosis with polyangiitis, which is the same thing as Wegener granulomatosis. This disease has a triad of necrotizing granulomas, necrotizing or granulomatous vasculitis, and focal necrotizing, often crescentic, glomerulonephritis. The pathogenesis is T-cell mediated hypersensitivity response to inhaled microbial or other agents. The therapy is generally immunosuppression. PR3-ANCA is present in up to 95% of cases. The clinical presentation is that males are more commonly affected. It affects patients with an average age of 40. The clinical features include bilateral pulmonary lesions, chronic sinusitis, mucosal ulcerations of the nasopharynx, and renal disease. There is an 80% mortality within 1 year if there is no therapy given to the patient. Prognosis with therapy, including steroids, cyclophosphamide, and TNF antagonists, gives a better prognosis with a chronic, relapsing, remitting disease. Here is our gross picture. Go ahead and describe the slide. The answer will be on the next slide. You can see this is a left lung because there is one upper lobe and one lower lobe. The right lung would, of course, have 3 lobes. You can see there are large centrally cavitating lesions. Here are the microscopic pictures. Go ahead and describe them. The answers will be on the next slide. You can see on the top right is a necrotizing granuloma. The pink region on the left is necrotic tissue, and there are a couple giant cells. There are probably also histiocytes present, but this pattern is generally referred to as necrotizing granuloma. You can also see there is at least one blood vessel that has a granuloma in the wall. You can see that on the lower left and on the lower right, there is a higher power demonstrating the granuloma present in the wall of a blood vessel. Let's go on to thromboangiitis obliterans, which is the same as Buerger disease. This is a segmental thrombosing acute and chronic inflammation of medium-sized and small arteries, which principally affect the tibial and radial arteries. The patient should not have atherosclerosis for this diagnosis to be considered. The clinical presentation is generally heavy cigarette smokers, usually before the age of 35. The patients will also have cold-induced Raynaud phenomenon and leg pain. Here is our pathology. This blood vessel demonstrates acute and chronic inflammation in the wall. It has a thrombus, and the black arrow points to an abscess within the thrombus. Okay, that's it.